It is showtime. All right. Good morning, good afternoon, good evening, depending on when and where you are watching this live. This is the face and the voice of Dr. Tolu Olabintan, CEO, founder of Livingspring Family Medical Center here in the city of Mansfield, Texas, where we believe in helping patients live well and live long because we believe that the length of your life or the quantity of your life is just as important as the quality of your life. It's a Saturday morning here in Mansfield, and I am honored and excited to bring on my friend, Dr. Judit Staneata, who is a physical medicine and rehab physician. Without further ado, I'm going to hand over to you, Doc. Please kindly introduce yourself. Who are you and what do you do?
Good morning, everyone. Thank you so much, Dr. Olabintan, to have me on the show. It's very exciting to be here. So as you mentioned, I'm Dr. Staneata. I practice physical medicine and rehabilitation, or physiatry. That's another name for our specialty. And I am in North Carolina, just a little bit ahead of you in time, so to say. But yes, so physical medicine rehabilitation, our specialty includes a wide variety of treating patients and conditions of the spine, the nervous system, the brain, musculoskeletal system. So it's very, very broad. However, I specialize in interventional spinal procedures, joint injections, nerve blocks, different kind of botulinum toxin injections. So again, helping patients to restore their function, improve quality of life, and be able to enjoy life at every stage, despite different type of injuries they have encountered either during their lives, or acute injuries, acute and chronic injuries I see a lot, or even maintaining or slowing progression of certain conditions, right? And that's my passion, and that's what I focus on every day.
Awesome. I like that you help improve the quality of patients' life, even if they've had back injury. So it doesn't mean that the things they enjoy is necessarily over. You help them even with that. So that's awesome. Now, inquiring minds want to know, how did you hone in on this specialty? Why do you do what you do? And if there's a story behind it, please share.
Absolutely. Long story short, I am from Romania, from Transylvania, and I went to medical school, and I wanted to become a surgeon, specifically an orthopedic surgeon. So I started my residency over there, and then life happens, and I won the lottery, the diversity visa lottery. So moved to the United States, almost 16 years ago, and here getting into a high-end specialty. Orthopedics is one of them. It's more difficult. However, I went through the testing, the board certifications, and the physical medicine and rehabilitation is the closest one that gets to the musculoskeletal system. And again, to restore, coming back to the same point, to restore function. Also in my family, my stepfather had a stroke when he was at a very young age, and he was paralyzed. So I wish I would have all the means or knowledge back then to help him to restore more of his function. So that kind of stuck with me growing up, that there has to be something that helps these patients. They cannot be just, marginalized and not being able to enjoy life with their families, even though some of them cannot return to work. But here, lately we have great breakthroughs for even those patients with recoveries and aids and all kinds of means we have to help them to continue to live and function, actually. Anyway, so that's the long story short. So physical medicine rehabilitation definitely tucked to my heart, and I like the outcomes. I like the results. I like, when I inject a patient with botulinum toxin, their spasticity gets better, or the spinal injections, they have acute pain, radiculopathy, cervical, lumbar, and you inject them and they feel better and they come back. Oh my gosh, thank you so much. And we go from there, so it's not 100%, nothing is 100%, but definitely helps patients to get back to where they were before.
Awesome, awesome, awesome. And it's nice to see that instant relief sometimes, from some of
Yes.
the procedures. That is like, wow, yay. Awesome. All right. So let's talk the back. Now, people come in and say, oh, my back hurts. So I kind of want you to kind of break it down for our patients, the cervical part of the back, the thoracic part of the back, the lumbar, and then sacral if you got a chance. So please kindly explain the different parts of the back.
Absolutely. So the cervical spine is the upper part, so it's between, from the cranium down. We have 7 vertebral bodies and 8 nerves. So that's where the nomenclature a little bit messed up. That's all like medical lingo, and we speak that language, so no problems. Cervical spine, as I said, so it's a free moving part of our body, right? We have the head attached, which is very heavy, and then we have our trunk, which is a more robust portion. So unfortunately, in the cervical spine, it is deemed to suffer injuries, because it's freely moving. So that's one part. Then we have the thoracic spine, which is the next 12 vertebral bodies, and it's more robust. It's more way less movement, because we have the rib cage, which protects it, and it's very important because inside we have our chest and our abdomen, upper part of the abdomen, and it has to protect our vital organs, right? We have the heart and the lungs. So it's very amazing how good Lord created us in this fashion, because it makes sense. Actually, it makes sense why is it in a certain way. Now, the cervical spine and the thoracic spine both house the spinal cord itself. Now, the spinal cord is definitely the vital organ continuation of the brain, and then we have the nerve roots coming out, continuing down all the way to the lumbar spine. However, the spinal cord ends at the T12, so the bottom thoracic vertebral body, or L1, L2. It depends the lumbar portion. Excuse me. The lumbar spine, for the most part, has 5 vertebral bodies, sometimes 6, sometimes 4. I see lots of variation, and patients are like, oh my gosh, that's not normal. I'm like, it's variation to normal. It's just interesting. So many times when I see a little, sacralization of the last vertebral body or lumbarization of the first sacral segment, you always go up and count and make sure, we have a good, and it's interesting, many times it's not even picked up on MRIs. It's like come on. It's yeah, very interesting. Yeah. And so the lumbar spine, again, it's a more mobile segment. That's why, again, it's a free segment between the big robust thorax, our trunk, and then we have the pelvis, which is, again, stabilizes us. We have both hips, and it's more like an even distribution of the forces every time we take a step. The lumbar spine, as I mentioned, the nerves exit. We have the cauda equina. It's a fancy name of a horsetail, the nerves running down, branching out, and controlling our legs. At this point in the lumbar spine, it's not as much risk of, of course, we don't have the spinal cord, no spinal cord injury itself. However, nerve injuries and other things can happen. And that's why, because it's so mobile, especially that last segment or the last 2 segments between 4-5 and 5-1, 5S1 being the first sacral segment, it's lots of movement there, and that's where we get most of our degeneration. It's just a natural progression, because we are biped, we walk on 2 feet, right? And then we have the sacral segment again, which is like a triangle shape. It looks like, but we have 4 or 5 segments depending, and then we have the coccyx, the sacrococcygeal joint, which is again very prone to injuries when patients land with in a sitting position. Here where I work, I'm by one of the largest military bases in the United States. Lots of parachute incidents with our soldiers, so they hit the ground hard, and lots of injuries in the sacrococcygeal junction, fractures, which they heal, but many times they have sequelae of pain long term. So in a nutshell, that is the skeletal breakdown of the back. When a patient comes in, many times they say, "Oh, my back hurts," and then the sacrum and the SI joints. It's a very interesting pain generator, in a sense that that's where the spine and the pelvis come together. And many times patients come in, "Oh, my back hurts, my lower back," but it's not necessarily the lumbar spine. It is a lower segment, and it's to the sides below the waistline, and it kind of radiates out. So that can be confused sometimes with radiculopathy. So a good physical exam, you can pick up on it, and it's very straightforward.
Okay, so knowing what part of the back hurts is important, and you depending on where they're having their pain, cervical, thoracic, lumbar, sacral, coccyx area. So we just got schooled on the different parts of the back. So that's why the doctor will ask you, well, what part? Because there's a difference with each segment as far as mobility, like you highlighted. Thank you, Doc. Next question. Let's talk neck. So cervical injury, acute. Can you give us examples and how you manage that?
Absolutely. So acute injury is usually something happened. So an event like an injury, most very, very common what I see, again, car accidents, right? The motor vehicle collisions, that's when the patients, that sudden movement of flexion extension within seconds, when, let's say if it's like either lateral or even T-bone, like from behind hitting the car, or the car hits somebody, you go forward, backwards very fast, and that's what we call whiplash. The reason it's whiplash because it's so fast and it goes like this, right? Anterior, posterior, it can go side to side. So that immediately our body reacts. So it's so sudden that we don't have time to brace ourselves. If you see it coming and you brace yourself, the impact is not as high. However, most of the time we don't know that's going to happen. So our body just stiffens up the muscles immediately because our brain tries to protect us and tells the muscles spasm. So they immediately spasm up to protect the cervical spine, the vital organ, which is the spinal cord, right? And many times these patients end up with the so-called whiplash injury, which is very, very common. It can be very nagging. It can take up to, I would tell my patients 6, 9, 12, 24 months to get better. And many times it becomes a chronic muscle spasm, which we call cervical dystonia, where their necks like lock up in a position. And, for that we have other treatments, but it's very, very common. So that's one of them. Sport injuries, lots of them can happen. In my patient populations, I have the paratrooping injuries and falls. In our older population, when they fall, many times, because they already have some underlying degenerative changes. So I want everybody to be clear, everybody's going to get arthritis in the spine. Depends. Just the question is when. It's one of those things, our bodies, degenerate, and depending on what our activity level was throughout our lives, some genetics as well. But if we maintain like a healthy lifestyle, we can slow the process, but it's going to happen regardless. So coming back to the acute injuries, it's different based on age groups, right? So children can be different, less likely. The motor vehicle collisions are big, chunk of patients populations between 20, 22, all the way down to 60, 65. And then above 65, our patients have more like the fall-related injuries where they experience the central core syndrome. Many times that can happen, the patients hit their head or their neck, and they are like, oh my goodness, I can't feel my arms. I can't do anything with my arms, but they are walking fine. So that's like an acute injury to the spinal cord. Actually, it's an inflammation. It recovers for the most part. Sometimes surgery is needed, like it's an emergency, but they do well. Now, when it's an acute injury, unfortunately, from the spinal, like it's a fall, like let's say from heights, patients can, or a diving injury, patients can suffer spinal cord injury, where they get paralyzed from whatever level the injury was, or blast injuries. We see it in soldiers, unfortunately, or gunshot wounds. When it's towards, they go through this cord or severe the cord, and those patients get paralyzed, and depending what level, that's whatever function they are going to have from there on. So it's definitely it's a serious aspect of our body. We cannot take it lightly. For the most part, what we deal with is really acute and chronic injuries. So they had underlying degenerative changes, degenerative disc disease or arthritis, and then if they injured, then everything just like flares up. Or patients can, let's say, sometimes they lift up something heavy and it doesn't affect the lower back, or they push something overhead. Activities can bring on like an acute radiculopathy in the upper extremities. Or sometimes patients say, nothing, I haven't done anything, and I walk up with excruciating pain going down my arm, and it was a slow process, and it just so happened that the disc just bulged or protruded at that point in time for whatever reason, and it's putting pressure on the nerve root or nerve roots, and it needs to be taken care of. So treatment-wise, depending on so if it's more like we suspect it's more muscle, there is no neurological deficiency, then we go ahead and start out with medications like a muscle relaxer. If it has a nerve component to it, then always anti-inflammatories, something for the nerve pain, and start physical therapy. Many times, if it's warranted, we do recommend imaging, right? At least X-rays. We do that for the most part, in our office now. But many times we recommend this computer tomograph, a CT scan, or MRI, which is more specific for the soft tissue injuries, such as the spinal cord, the nerve roots, and the discs. So those would be the first steps. And then based on what the patient, if it's more than, like, let's say, we suspect cervical radiculopathy, then definitely we would recommend an injection, transforaminal epidural steroid injection, to put the medication straight to the source of the whichever nerve is being irritated and inflamed. Now, if it's really acute and there has been neurological deficits, then it's a hospitalization, and from there has to be taken on. Yeah.
Of course, of course. There are some things you highlighted, from a preventive standpoint, as family physicians, we're thinking, how can we prevent these things? Now, some things happen, unfortunately, the gunshot wounds with a car accidents. Of course, if you know ahead of time, like you said, your body can stiffen to protect your spinal cord. But you mentioned the lifting. So careful about lifting, and of course about fall prevention. So can we just pivot real quick and just talk briefly about that? Is there a way to lift? For those who are watching, who are like, look, that's my line of work. I mean, I lift all day. Is there a way to lift that would prevent some of these injuries?
Absolutely. So we always recommend not bending, but squatting way as much as possible, and have a back brace, especially for those patients, because it's mostly the lower back. With the neck, patients who do repetitive movements, and this is for workplace, especially when they do repetitive movements, when they have to look up and then put something, stocking shelves, right, up higher than their height, and they have to do it, and they look up and then push and then lift heavy. So what I would always tell my patients, try to break it down. Don't lift the whole 50 pounds at once. Do 30, or have help. Or I'm really hoping that 21st century United States, I'm hoping that these workplaces have accommodated these kind to prevent these injuries for the most part. Hopefully that they have forklifts and help their employees. However, things happen, but that's the biggest one. To the right way to lift, squatting down as much as possible and lift if it's from ground level. Many times I tell my patients, you have to carry all this, bring it up. Again, break the weight down if possible, have help, bring it up to a waist level, and it's easier for you to lift it from there. You don't have to bend over or flex or squat, and you just carry it at the same level, and it's much easier that way than bending over, doing, because it's so many movements are involved. And patients are strong, and we do what we have to do for in order to work and all that stuff, but always be very mindful. And I'm hoping that there's workplace education, and definitely the back braces are always recommended for my patients. For the cervical spine, not much prevention other than just be very mindful and break the weight down as much as possible.
Awesome. The back brace, and and the lifting, the squatting. And then you could do it in chunks as opposed to carrying the whole thing at once. If you could break it down, go ahead and break that down. Now let's talk about fall prevention. I talk about this a lot with my patients. What would you say are ways to prevent falls, especially for the elderly?
Yes.
Mhm.
So especially for the elderly, so most of them happen at night. Because they, have to get out, they have to use the bathroom, which is, it happens. What I tell them always, have a cane or a walker by the bed. Nobody sees you. You're not outside. Sometimes patients are, like, I don't want to, do this in the public. It's, I'm not that old. And I'm like, I get it, but for your own safety.
Mhm.
So that's the first thing. Second thing, clear out the space between the bed and the bathroom. Don't have a little rag or a little carpet, depending. I always ask them, do you have a carpeted bedroom? Do you have, hardwood floors? How does it look like? Because if it's like a carpeted bedroom, then I just always tell them, don't have anything on top of that carpet between your bed and your bedroom, the walkway where you have to go. So you don't get hung up on anything, because you can trip, you can fall. And in the bathroom, the same thing. Try to avoid any kind of small rags, any kind of, which can get between you and being able to maintain walking and standing and not to trip and fall. The biggest one is really the either a cane or a walker to have by their beds, because sometimes these patients take medications at bedtime, and they wake up, they sit up really fast. We have the hypotensive response, right? It's right there. And even when you don't take medications, you can become hypotensive when you sit up really fast, and that's when it happens. They take a couple of steps, and they can fall and injure, and that's why we have so many fall related injuries. And sometimes they can get up. They don't have their phone on them. We don't sleep with hope not with our phones in our pockets, or they don't live with anyone, or they are elderly. They don't have like a safety brace or a safety necklace where they can call, or so that EMS can be dispatched. So it's a very it's almost like we have these general kind of guidelines we recommend, but then we have to assess every patient by their unique situations, yeah, and their unique living situations. Yeah.
Awesome, awesome. I like the emphasis you made on, the elderly not liking to use the cane. I have I have one patient in particular, and she's like, no, she limps, and I'm like, she's like, no, I will not be caught outside with a cane. Eventually, we were able to beg her to get one, and it was styled, it was decorated, so it looked kind of, cool. But really important. These things are important for those who are watching. For the elderly, those who have to kind of get up out of bed at night more frequently than usual. And even having a well lit walkway, like
Yes,
little
yes.
lights in the pathway, so you can track yourself, is also a good idea.
That was
Awesome.
my next suggestion. And then the same thing in the house, try to avoid any kind of like little rags, like, how mostly kitchens, they're either hardwood floors or kind of, tile, linoleum, whatever it is, try to avoid so you don't trip. You don't. The other thing what I suggest my patients, don't pile up your cabinets up high. Bring everything down to eye level. It's
Mm.
very important because that's, they climb up, even if it's just a step stool, they can fall and they get dizzy, and not just our elderly population, even us. I mean, it can happen to anybody, and try to avoid all that. Everything to eye level, stuck your cabinets, everything, so you don't have to avoid, like, just you're protecting yourself at the end of the day. So.
Awesome, awesome. So now let's talk lower back, lumbar spine injuries. I think you highlighted that a little bit as well. But let's talk examples of those and how you manage that.
Absolutely. So, lumbar spine injuries, again, we can break it down by population ages. Like if it's a younger patient, let's say they are very active, they are working, very strong. It doesn't mean that it cannot happen, right? I see it in my very young in their 20s and 30s soldiers. They come in with acute radicular pain because something, and it doesn't have to necessarily always be a parachuting incident. It can be just from running or weightlifting, or because they have to train, right?
Right.
I remember the one time when my back problems started, so I can relate to my patients. My son was I think he was 3. Yes, he was 3 years old, and I he really liked me to pick him up, and he was the airplane, and he would spread his arms out, and then let's just so I was holding him with my hands out. He was across horizontal, and I was doing this twisting movement. Well, I felt kind of a pop in my lower back, and I was like, oh, okay. The next morning, radiating, shooting pain down my right leg, and that's how it started. So I have, lumbar radiculopathy. That's how the degeneration started. Of course, in females, we have the our body takes a hit with pregnancies. And that was my first child, but I didn't know. I didn't necessarily pay attention. I'm like, oh, I'm young, it should be fine. But because our spine takes that lordotic curvature because of the weight of the baby, it's more pressure on the discs, so it can happen. So this was like, he was 3 years old, and I twisted, and I had a disc protrusion, which means that the disc kind of squished out, and I was pushing on my nerves. So thankfully I was working, and I got an MRI and all this stuff, and they explained it to me, and I'm like, okay. And it got better with some anti-inflammatories. That was the first one, and then 4 years later, when I had my my little one, it was way worse. It was way worse. So that's one patient population, right? Younger patients, it's usually a disc type issue. If it's bad enough, like we start out with a high dose of metal dose pack or a prednisone taper for 12 days or so. I usually do a higher dose just to kind of hit it hard, that inflammatory process, kind of calm it down. If they don't get better, definitely try physical therapy. By that time, we definitely recommend imaging, especially if there is some weakness involved in whatever nerve distribution that happens. And then many times patients choose the route of, let's just do an injection, because anti-inflammatories go through the whole body. They work really well, but many times putting the medication right at the source, it just works much better and faster. And again, we want to get back to what we need to do to our daily activities. So it's one of those things where, why not? Let's get better. And then from there on, our next patient population, so that's discogenic pain for younger patients for the most part. Now, as the time goes by, our this generation happens. And then once our discs are not as healthy as they should be, so the space in between the vertebral bodies diminishes, then the facet joints, the joints in between the vertebral bodies posteriorly, they take the hit. So the way the weight is distributed, or the axial load coming, from gravity, our facet joints take up about 30-35% of the body weight, and that's how, when we walk and we stand. Once there's this degeneration, that doubles. It goes to 65-70%. So our facet joints start wearing out. They are tiny, small synovial joints, and we have the movement in the lumbar spine since we were born. We are going forward, backwards, turning, twisting, bending, all the movements. And then on top of that, having this extra pressure is gonna wear those joints out. And then we start having this axial back pain. Doesn't really radiate. It's just in the back, and it's worse with extension. As we age, it gets worse. Our joints kind of dry out, and when you walk around, in one of the supermarkets, or even Walmart, and you look around our geriatric population, usually they are bent forward with their elbows on the carts, and that's a natural subconscious kind of way of our body saying that, hey, if I'm on in a neutral position or extension, it hurts, because it lowers the facet joints, and there is like this chronic kind of degenerative changes and inflammation, and our body just tends to get itself out of pain. For those, we recommend either intraarticular facet joint injections, physical therapy, good posture, strengthening the core muscles, and we can also do radiofrequency ablation, which is kind of deadening those little nerve endings which pick up the pain, because you can do surgery for those. I mean, it's both levels, both sides, multiple levels. And once we do that, the patients actually have more function because the pain is not as intense. And then I recommend to become, go to physical therapy, strengthen up your core. And they are just thankful because they can do more. They can actually enjoy their retirement or family life, or, their grandchildren, and so on and so forth. Yeah, so it's a lot. It's very broad, but those are kind of the basic ones. Do we treat axial back pain? Do we treat recurrent pain, which is radiating nerve root involvement, discogenic type pain? And then here, kind of, it comes into play the SI joints as well, the sacroiliac joints, and the other small joints in the spine.
Awesome. So different pain points in the lumbar area for different populations. And then different treatment options, of course, depending on the age and the duplicity of where the problem is.
Yes.
Like you mentioned. Now, of course, this is medical. These are medical suggestions. We do recommend, seeing your doctor to come up with an individualized plan for you.
Yes.
I like that you mentioned physical therapy. I like that you mentioned, deadening some of the nerves, so we numb the areas so you don't respond with pain so often, and you're freer to do some of the things that you enjoy doing. So quality of life is improved even without surgery. I love that. Now, the next question I have for you is, last question is compression fractures. I mean, not fractions, fractures. What are those, and how do you manage that?
Okay, so compression fractures happen usually when the bone health is not as good as it should be. That's the most frequent one, unless it's an acute injury, because unfortunately it can happen with motor vehicular accidents as well in younger populations. Again, gunshot wounds and falls like from height. I have unfortunately a couple of patients in their 20s fell off a roof and they suffered spinal cord injury because the compression fracture was acute. It was so sudden, and it lodged into the spinal cord, and they become paralyzed from waist down. Those are the extremes. The most common one is mostly in our patient populations who have either osteopenia or osteoporosis, mostly osteoporotic patients. And how it happens, they can either just bend forward or lift something not heavy, just the wrong movement, and the disc collapses. Now, these usually are not emergency, in a sense that usually it happens at the T12, the thoracolumbar junction. The reason why it happens, because we have the thoracic spine, it's this big, robust structure because the ribs are protecting it, and then we have the lumbar spine, which freely flows down, right? Runs down 5 more vertebral bodies, and it's almost like a weakening spot. So that's why we have so many T11, T12, L1 compression fractures in our elderly population, because the bone structure is weaker, and that's where our bending starts, right? Thoracic spine, we don't have too much movement. So it's very, very common, unfortunately, but it's not a medical emergency for the most part, because if the vertebral body height is this, it just kind of, usually it's 30%, 35%, sometimes it's more. if it's caught right away, because sometimes patients are like, oh, I just pulled a muscle, I'm not sure it happened 3-4 weeks ago, which is still fine, but sometimes they come in and it's a subacute fracture, it happened 3 months ago, sometimes it was 6 months ago, and nothing, the patient just kind of put up with it, and they're like, yeah, I wasn't doing much either, and I was just in pain, and I was sitting around a bit more. But if it's caught early, it can be fixed, in the sense that, it actually, patients, because it's very painful. It's very painful until kind of everything kind of settles down, and that acute process that kind of diminishes. But we can treat it with kyphoplasty or vertebroplasty, which are the two options for rebuilding the height. Of course, we are not thinking 100%, but injecting artificial cement into that area to rebuild, pain goes away instantly. And it's a very rewarding kind of situation. Now, patients who wait a little longer, or it's only like 15-20%, but we don't recommend kyphoplasty for those. So it has to be a certain amount of percentage to be eligible for that, to rebuild it up. Because if it's only 15-20% of fracture, okay, it's going to get better, the pain, and it's not changing too much in the height or anything, but there is pain. Many times we do injections, just regular epidural steroid injections, because putting the medication right at the area, it kind of calms it down. Now, physical therapy, once the acute phase is over, physical therapy is important with a back brace to strengthen the core. And we don't recommend, and for the patients to learn, we teach them to avoid flexion, right? Because when we go forward, there is a higher chance to have that compression fracture to either progress or to have another one, a different level, right? So, back brace, definitely just to remind them that not to bend, and physical therapy to strengthen the core muscles, and to be able to do different activities they need to do, or activities of daily living around their house, to prevent further injuries in the same place or a different level.
Awesome. A lot of information here, Doc. And you mentioned something, so I wanted to kind of highlight from a preventive standpoint. You said osteoporosis, osteopenia as a common source of compression fractures, especially for those who are older or who have been on steroids for a while, or have any underlying issues that kind of eat at the bone. And so that's different from osteoarthritis. So osteoarthritis is between the joints, right? The cushioning is less. Osteoporosis, the bone itself is thinner, and so more prone to breaking with a mild injury or a mild fall or a mild bump. So from a preventive standpoint, I just wanted to highlight really important, bone screening, bone density screenings for our patients who fall in certain risk factor groups. So if you've been on steroids for a while, you may do that earlier just to make sure the bones are not thin, but generally anywhere from 60s and up typically, and earlier if there are reasons to. And how can you minimize the risk of osteoporosis? Make sure your vitamin D intake is good. So just wanted to throw that in there as a preventive way to make sure that, we're not at risk for osteoporosis. This has been very, 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 very informative. I've learned tools here also to encourage my patients. And for those who are watching, please share this with those who could find this useful. But Doc, people are probably wondering, this doc, I like, what he does. She's obviously passionate about helping people feel better. And they wonder, well, how can I connect with her? So Doc, where can we find you?
Absolutely. So on Facebook, of course, Dr. Andrea Staneata. That's my middle name. I know you introduced me with Judith. That's my first name, but just easier. And then the same on LinkedIn, Dr. Andrea Staneata, MD. Instagram, I blanked, and TikTok. I'm trying to put it out there, some short informative videos. When where I live, I know TikTok works a little different, but if patients watch it and they ask a question, I try to answer, and it's just very informative. It's more like I feel it's more interactive and more non-formal. Of course, I always say, just like as you mentioned, Dr. Olabintan, that definitely go to your doctor, get their advice. I'm not your treating physician, but these are certain things you can expect or look into, and I'm more than happy to help anyone who reaches out to me. Yeah.
Awesome, and I'll be sure to put you also for those who are in North Carolina who want to come see you. They have that option to have you as a physician, as a treating physician.
Thank you.
Thank you all so much for watching. It's been a pleasure and a privilege to share this information with you. Thank you. And on a closing note, if you or anyone you know is looking for a thorough, a passionate and a caring family physician here in the Mansfield area. I am she. Thank you so much for watching. Have a good day.
Thank you. Bye.